Everybody, this is Dr. Fathman. Going to go over the rapid fire review for test 4. You're almost there. Hang in there. So let's start with musculoskeletal complaints. We're going to start with low back pain. Lumbar strain, low back strain causes are often unclear. Could be an acute injury, could be subacute or chronic. Usually follows an injury. Subacute or chronic are more common, and there may be no recollection of injury in those cases. But the most important thing is to figure out the mechanism of injury, like what happened. Herniation can occurs with tears sometimes in this with low back pain. Annulus fibrosis causes the contents of the pulposa to protrude. That's what a herniation is. To prevent or protect against these injuries requires proper body mechanics. Maintaining a healthy weight can help prevent this, and a state of conditioning where you have increased or adequate core strength. Risk factors for back injury or low back pain include overweight and or obesity, mechanical disorders such as scoliosis, kyphosis, or osteoporosis. There are other non-mechanical disorders such as prostate cancer, pelvic and renal disease, so cancer with METs, for example. Occupational strains occur. Sometimes leg length differences can contribute to the low back pain. Poor posture, poor body mechanics. On the history, you want to assess the past medical history. Is there any history of back pain? Has this ever happened before? Prior treatment, outcome, any recent weight loss or gain, any history of chronic disease or chronic comorbidities. Medication use, are they taking NSAIDs every day for osteoarthritis? Is there, and what relief are they getting from NSAIDs if it was even an acute injury? Did they get relief with any topical medications, and or if they had taken steroids or had a history of that? Do they have a family history of cancer, osteoporosis, osteoarthritis, rheumatoid arthritis? Any social history? What do they do for a living? What other stressors do they have? Do they drink alcohol, smoke tobacco, use other illicit drugs? What is their exercise history? But in order to really diagnose the problem, you have to assess the mechanism of injury, and that is done during the history of present illness. First thing you do. Are there associated symptoms such as weakness, change in sensation, weight loss, fever, malaise? Are there bowel and bladder changes, sleep disturbance? Does this wake them up out of bed or out of a sound sleep? GU symptoms, genitourinary symptoms associated with it. Are they having night sweats? And what impact is the pain having on their activities of daily living? Lumbosacral strain. There's typically minimal pain at the time of the event, but increases with stiffness occurring 12 to 36 hours after, and this is a result of the soft tissue swelling. So they may feel fine the day of and not notice anything, but the next day it's like they can hardly get out of bed. Been there, done that. Not as good as I once was. So the pain could be in the back, radiate to the buttock or thigh. They may have pain with a straight leg raise. The pain's increased with movement on standing, and it's typically relieved with rest, but they need to keep walking, moving, maintain usual activities and walking in order, like as it heals. The last thing you want to do is say, stop moving or bed rest. A herniated disc. So a herniation is going to produce a radicular type pain, a radiculopathy, which is that shooting electric pain down to below the knee, back of the butt, into the knee, around the calf, also referred to sciatic pain. It's worsened with when you have a herniated disc, the pain is worse with a Valsalva maneuver. They may have numbness along the nerve root and sensation change, and they will have, again, a positive straight leg raise, which is just pain on elevation on the straight leg raise. The neuromusculoskeletal exam, when it comes to assessing the back, you want to do deep tendon reflexes of the knee, which would, which innervates at L4, and the Achilles, which is S1. And this will be absent or diminished with a herniated nucleus propulsus. Weakness and dorsiflexion of the ankle or great toe suggests L4-5 nerve root dysfunction. And you want to assess light touch of the medial, which is L4, dorsal L5, and lateral S1 of the foot. So the foot assessment is L4, L5, and S1. You want to perform straight leg raise, sitting and lying, standard and crossed is the gold standard for assessing this. L5 S1 disc prolapse, you're going to get pain along the posterior thigh with radiation to the heel. Weakness on plantar flexion. Sensory loss in the lateral foot, and absent ankle jerk reflex. This is mostly S1 in that case, the ankle jerk. L4, L5 disc prolapse or innervation will present as pain along the posterior lateral thigh with radiation to the top of the foot, weakness of dorsiflexion of the great toe and foot, paresthesia and numbness of the top of the foot and great toe. Typically no reflex changes noted. L3, L4 is pain in the front of the thigh. Wasting of the quadriceps muscle could be present depending on how long it's happened. How long it's been going on, diminished sensation in the front of the thigh and medial lower leg, reduced knee jerk reflex, mostly L4. The AHCPR guidelines are applicable for ages 18 to 50 with back pain less than 3 months duration. So you search for red flags, perform frequent clinical reevaluations. Focuses on improving patients' activity tolerance. The worst thing is inactivity. They need to keep moving. So typically, if it looks like a strain, the guidelines recommend delaying imaging studies for 4 to 6 weeks as long as there are no red flags and no neurological dysfunction and no abnormal neurological findings. Three red flags when it comes to low back pain that are critical to rule out are fracture. Is there recent trauma? Were they in the motor vehicle accident, fall? Do they have a history of osteoporosis? Sometimes just moving in the bed, if you have a severe case of osteoporosis, can result in a vertebral fracture. I've seen that happen when I was working in the hospital. You also need to consider tumors and or infections, so more chronic systemic illness situations. This occurs more commonly in people over the age of 50 or under the age of 20, particularly with a history of cancer. They'll also have constitutional symptoms such as fever, chills, weight loss, malaise. They just don't feel good. They may have experienced a recent infection. This could be more common among IV drug users and those who are immunosuppressed. In this case, the pain worsens when supine or they get no improvement with changes in position. Often results in severe nighttime pain. Cauda-Equina syndrome indicates nerve root compression and will result in saddle anesthesia or perineal numbness. It may have a recent onset of bladder dysfunction and severe or progressive neurodeficits in the legs, unexpected laxity of the anal sphincter, perianal and perineal sensory loss, knee extension, weakness, or foot drop. So urgent neuroimaging is recommended in the initial assessment for patients with any of the following conditions. So you're going to do imaging right away in these cases. First, acute radiculopathy with progressive neurological deficit, radiculopathy with urinary retention, saddle anesthesia, or bilateral neurological signs and symptoms, suspected neoplasm, suspected epidural abscess. There is no justification for imaging studies within the first 30 days of complaint when all other things are excluded and they have no neurological deficits. Back pain that persists for more than 4 weeks, however, needs to be followed up with a CBC, a SED rate, X-ray, and bone scan, potentially, depending on what the X-ray shows. And if they're concerned about the potential for stenosis, may follow with MRI and CT after the plain radiograph and or CT. Sciatica may require surgical referral. MRI, CT, or EMG imaging is indicated. Musculoskeletal injury. So we're looking at stress fractures, or we're talking about stress fractures right now, and these occur as a result of repetitive forces applied to the lower legs during strenuous activity like runners, distance runners, for example. Fatigues of the muscles causes tiny cracks in the bone. It takes about 4 to 12 weeks for most of these to heal. This is not uncommon among women experiencing the female athlete triad. So the females are more susceptible. In this, the triad is amenorrhea, osteoporosis, and bulimia and or anorexia. So it's a nutritional deficit as well as a hormonal deficit, particularly estrogen, that puts women at higher risk for this. Just as when we hit menopause, we are at higher risk for osteoporosis because of the lack of estrogen. This occurs when you have low estrogen in younger female athletes. So tibial fracture is common, the tibial stress fractures with athletes. There's diffuse tenderness is pretty typical. It occurs at the start of the activity, resolves with rest, and then eventually becomes continuous. The femoral neck is also a common spot for stress fractures. We see this more commonly with dancers and long distance runners. Pain here is typically in the groin. This can progress to avascular necrosis, an osteonecrosis of the femoral head. Pelvic fracture is most common among long-distance runners, pain in the inguinal, perineal, or adductor area after an increase in training typically. They may not be able to stand on the affected side. Healing can take 3 to 5 months. Shoulder. We see bursitis occurring in the shoulder, which produces inflammation, pain, tenderness of the bursa, and tendinitis. It can be a result of infection, trauma, prolonged pressure, gout, or rheumatoid arthritis. Typically, it has an abrupt onset. There's focal tenderness, swelling with flexion. Extension is most comfortable actually in this situation. Range of motion is not as limited, but they will have a positive arc test, which is pain when you raise up the arm between 60 and 100 degrees with active abduction. So it's sort of raising it out to the side to 60 to 100 degrees will cause pain. Now, rotator cuff is a partial or full tear in the rotator cuff there. We see this most commonly among painters, drywallers, tennis players. This pain increases at night and will wake them from sleep. They have difficulty abducting. There's crepitus, pain with palpation, and asymmetric movement. You'll get a positive drop sign and a positive arc test beyond 90 degrees and a positive near test, which is that passive arc. Elbow. Injuries occur from repetitive wrist and elbow use. One in particularly that is common is epicondylitis. So we have a lateral epicondyle and a medial epicondyle. Lateral epicondyle is commonly found among patients who are tennis players, often referred to as tennis elbow. So in this case, you'll have a positive quote-unquote book test, which is where you can't really hold the book out straight on your arm, or like even a purse hanging on the hand with your arm outstretched, and there's pain there in the elbow. That would be a positive book test, and they just don't have the strength to be able to hold it up. The golfer's elbow is from medial epicondylitis. So there's also radial head subluxation or nursemaid's elbow. This is a common elbow injury occurring between the ages of 1 and 4 as a result of a sudden or vigorous pull on the arm, results in sudden pain with inability to use the arm. Elbow flexed and forearm pronated, held close to the body is how it's going to feel most comfortable. There's no bony tenderness or swelling at the affected joint. In the wrist, Colles fracture is a common injury as a result of a fall on an outstretched hand, a Fuchs injury. It's common adult fracture of the distal radius. You get pain and resistance to range of motion and the classic dinner fork appearance on the x-ray. actually on the x-ray and on the patient when they come in. It's like a deformity, a dinner fork deformity. They cannot hold a can of soup, like put their hand around a can of soup to hold it. Now, a scaphoid fracture is a common fracture of the carpal bone. It's common in young adults, also can occur from a fall on an outstretched hand. The wrist pain, though, in the scaphoid fracture is localized to the anatomical snuff box area when you push on it with palpation. So a couple of hand injuries, gamekeepers or skier's thumb is the ulnar collateral ligament injury caused by hyperabduction of the thumb. This occurs among skiers when their thumb strikes a fixed ski pole, for example. You get painful ulnar aspect of the MCP thumb joint. There's also the boxer's fracture, which affects the fifth metacarpal fracture from a forceful punch with a closed fist. It's the most common of all. It accounts for about 30 to 40% of all hand fractures, the boxer's fracture. There's swelling along the dorsum of hand and pain elicited with palpation of the fifth metatarsal. Common knee injuries we see. Osgood-Schlatter disease. This is most commonly found in late childhood and adolescent among boys, age 13 to 14, and more commonly than girls, which it occurs a little earlier, which makes sense because we tend to develop through puberty a little bit earlier, and occurs among girls around the age of 11 to 12. So there's painful swelling and point tenderness localized to the tibial tubercle. Knee extension worsens the pain. 30% of the cases, they'll have bilateral knee pain. This occurs with repetitive strenuous activity or sports. They may have a prominent tubercle there. It may be seen like sticking out a little bit. Self-limiting, this resolves after puberty without treatment. It's very frustrating though for the kiddos going through this. Patellofemoral pain syndrome. This is caused by overuse or overload or biomechanical problems and muscular dysfunction. So there's mild malalignment of the extensor mechanism of the knee and repetitive microtrauma from overuse. It's the most common complaints for runners. Females more than males because our pelvis has that exaggerated Q angle. Anterior knee pain typically occurs with activity and often worsens when you're going down steps or hills. Chondromalacia patella is a degeneration of the cartilage on the articular surface of the patella. It's caused by overuse and misalignment. It is infrequent in adolescence. This typically occurs as we age over time. Can be caused, though, by patellofemoral pain syndrome, and over time leads to chondromalacia patella. So it's sort of an extension of the patellofemoral pain syndrome that we just talked about. Iliotibial band syndrome. This is from overuse and friction between the iliotibial band and femoral condyle. It produces inflammation. Could be related to change in footwear, increase in running schedule, or prolonged downhill running. There's mild pain over the lateral side of the knee, typically, with IT band. The Ottawa knee rule. You get an x-ray only if you meet one or more of the following criteria, and this is almost 100% sensitive for a knee fracture. So meet one or more of the following: age 55 or older, isolated tenderness of the patella and with no other bony tenderness, tenderness of the head of the fibula, inability to flex at 90 degrees, or inability to bear weight immediately and walk more than 4 steps in the ER regardless of the limp. So if you have one of any of those, you will get an x-ray of the knee. Ankles. So sprains typically are due to injury injuring the lateral ligaments. That's 85% of sprains. Inversion injury to the lateral ligament. You get mild to severe swelling over the lateral ligaments. It can result in joint laxity, which you can assess with the positive anterior drawer sign of the ankle. Ottawa ankle rules. An x-ray is required if pain in the malleolar zone and one of the following. So if they have the ankle pain and bone tenderness along the distal 6 centimeters of the posterior edge of the fibula or tip of the lateral malleolus, or bone tenderness along the 6 centimeters of the posterior edge of the tibia or tip of the medial malleolus, so the fibula or the tibia, and lateral and medial malleolus, and inability to bear weight 4 steps both immediately and in the emergency room. So if they can't bear weight for 4 steps, you need to get an x-ray. So a grade 1 sprain is mild, grade 2 is moderate, grade 3 is very severe and usually involves a rupture of both the anterior and talofibular ligaments and the calcaneofibular ligament, and there's tremendous joint instability and they're unable to bear weight. So the higher the grade of the strain, the more severe it is. Foot. The Jones fracture is a fracture of the proximal fifth metatarsal. There's painful swollen lateral foot with pain elicited on palpation of the fifth metatarsal. High risk for non-union injuries despite optimal care. So even with this, they are at risk later for it to not heal well. Toe is swollen, contused, and painful upon palpation, and you would consider x-rays if there's significant swelling, effusion, or contusion. So other sources of joint pain, we see commonly carpal tunnel syndrome, which is the compression of the median nerve as it travels through the carpal tunnel. This is the most common focal mononeuropathy seen in clinical practice. Affects females more than males, about 3-to-1 rate. Risks include obesity, female pregnancy, history of diabetes, rheumatoid arthritis, and or family history of carpal tunnel. Prescription aromatase inhibitors, Arimidex, and Arimacin increase risk of this. Signs and symptoms include pain, paresthesia, weakness, which is less common in the median nerve distribution. Physical exam shows sensory motor and strength deficits, a positive Phelan and Tinel sign, positive manual carpal compression, pain, and positive hand elevation tests. The diagnostic test of choice, electrodiagnostic testing with nerve conduction studies, is the standard. So EMG is used only to exclude other diagnosis or assess the severity pre-op. Ultrasound or MRI you could use to rule out mass deformity or other bone or joint disease, although ultrasound is fairly specific for carpal tunnel. I don't know why we're not doing that more. Gout is an inflammatory arthritis caused by deposition of monosodium urate crystals in the joints, those MSU crystals. It is caused either by decreased excretion, which is 90% of cases, or increased production of uric acid. It results from an inborn error of purine metabolism and uric acid excretion. Asymptomatic hyperuricemia of 10 years or more typically occurs before the first episode of clinical gout. Risk factors: family history. 20 to 80% have a positive family history. Most risks for gout are non-modifiable, like age. It is the most common cause of inflammatory arthritis in men over 40. Alcohol. This is caused by reducing renal urate excretion. Beer worse than liquor or wine. Obesity associated with decreased urate clearance and increased urate production. Diet: foods rich in purine. Increases as serum uric acid levels rise. So uric acid levels over 9 milligrams per deciliter would be considered high, less than 7 to 9. Meds: 3 times higher risk for men with hypertension who are taking diuretics. It's about half of the new cases of gout are patients with hypertension, particularly men on a diuretic. Also aspirin, niacin, cyclosporin, and levodopa can increase risk. Associated disorders with gout include hyperlipidemia and diabetes mellitus. Lead exposure can also increase risk. Risk modifiers that can help reduce risk of gout include eating cherries, 10 to 12 cherries per serving, 3 servings over 2 days. Vitamin C, coffee 4 to 5 cups a day, and whole diets like the DASH diet. Signs and symptoms of a typical gout flare include severe pain, swelling, redness at the MTP joint, instep, ankle. Ulcer and bursa are the main target sites. Most commonly, it's lower extremity, single joint, base, great toe, that podagra. First attack typically begins at night and early morning. Pain peaks in 24 to 36 hours and subsides in days to weeks. The asymptomatic intervals become shorter with progression of disease. They can have mild and self-limiting inflammatory episodes. Polyarticular gout is rare, less than 20% of cases. These are more common among women. Physical findings with gout: severe tenderness and pain, redness, increased warmth, tenderness, effusion, limited range of motion of the affected joint. The classic podagra is that pain and erythema at the base of the great toe. It can occur in other joints though. Low-grade fever, leukocytosis may or may not be present, but typically not. You assess for non-painful tophi or tophaceous gout, which would occur over a long period of time. Joint stiffness of chronic gout. So the clinical diagnostic rule for gout, if a patient with a male sex gets 2 points, previously patient reported arthritis flare, another 2 points, onset within the last day, a half point. So what I mean by that is very acute onset of that pain. Joint redness gets a point. First metatarsal phalangeal joint involvement gets 2.5 points. History of hypertension or 1 cardiovascular disease gets 1.5 points. And if they have a serum urate level greater than 5.88, they get 3.5 points. So the probability would be low if they score less than 4, intermediate 4 to 8, high is over 8. If it's intermediate or high on this score, you would refer immediately for synovial fluid analysis. You would expect uric acid serum over 7 milligrams per deciliter, but at the time of the attack, of 20 to 30% could be normal. Most will have elevated though. Uric acid, the 24-hour urine measures excretion of uric acid. Normal is 600 to 900 on a regular diet. Over the 900 suggests overproduction of uric acid if their urinary excretion on a 24-hour urine is over 900. The gold standard is the joint aspiration for synovial fluid analysis, and this is really the only definitive method for diagnosing gout, and because you will see those urate crystals in the aspirate. Osteoarthritis. This is a degenerative joint disease causing breakdown of cartilage in the joints, leading to joint pain and stiffness. It is a degenerative joint disease, causes secondary changes to the bone. So in osteoarthritis, the smooth cartilage softens, swells, frays, ulcerates, and wears, loses the elasticity, and over time pieces wear away. So that wear and tear is transmitted to the bone. There's asymmetrical wear with all that in there, and then it breaks down over time. Aging is the greatest risk factor, and then risk is increased double if one parent is affected. There is a genetic predisposition, more so among females. Obesity is a particular problem, especially when it comes to knee. It affects the knees, produces joint instability, malformation, and inflammation, can also be caused by prior trauma, and hormonal factors can play a role. Signs and symptoms are asymmetrical complaints of pain. The pain is worse after overuse. It's worse after prolonged periods of inactivity and weather changes. You have morning stiffness or stiffness after rest. That's pretty short duration, usually under 30 minutes of morning stiffness. This is a slow onset, develops insidiously over weeks, months, or years, and there typically are no other signs of systemic illness, such as fever or other issues. Now, on physical exam, they have basically appearance looks normal, but they may have an antalgic gait, like it's not symmetrical. So they're like favoring a joint because of the discomfort. You may inspect the affected joints for deformities and or swelling, fluid. You would palpate the joints for crepitus, warmth, edema, or tenderness, and you assess the joint range of motion, strength, and stability. The Arthritis Foundation guidelines for diagnosing OA show joint pain, may see osteophytes on the X-ray, and one of the following. Over age 50, stiffness for 30 minutes, and crepitus is the guidelines for diagnosing OA. So you get an X-ray to test the baseline of the progression of the disease. You would expect unequal loss of joint space. So it's the loss of joint space that's visible on the X-rays from the wearing down. You may see osteophytes, which are bone chips or overgrowths, juxta-articular sclerosis from rubbing the joints, and subchondral bone sclerosis. Diagnostic tests include, they may be normal unless there's another morbid condition. So imaging start with X-ray, and then if that doesn't give you as many details, it may progress to MRI or CT. More typically an MRI, I would suggest. Rheumatoid arthritis. This is an autoimmune disease with a predilection for synovial tissue, affecting the synovial tissue, and you get associated tendon sheath damage. So it's an autoimmune inflammation of the synovial tissues resulting in the thickened synovium. It adheres to articular cartilage and later erodes the cartilage and underlying bone. There are adhesions between opposing joint surfaces and or cysts can develop. Sometimes the onset follows a virus, stress, surgery, infection, trauma, or pregnancy. The cartilage loss is symmetrical and in the early stages in the corner of the joint. So this is one of the things that differentiates it from osteoarthritis. In stage 1, the disease is present but asymptomatic, so you might get a positive RA on the blood test, but they aren't having any of the joint symptoms yet. In stage 2, it's interfering with activities of daily living. Stage 3, there's a major compromise in function and affects life and work. And in 4, results in complete incapacitation, mostly confined to bed or wheelchair. So for rheumatoid arthritis, the 2010 ACR-EULAR diagnostic criteria for rheumatoid arthritis, you have to meet all of the following. Inflammatory arthritis involving 3 or more joints, positive rheumatoid factor and or anti-citrullonated peptide or protein antibody, the anti-CCP antibody, elevated CRP and erythrocyte sedimentation rate. Other diseases will be excluded: psoriatic arthritis, acute viral polyarthritis, polyarticular gout, pseudogouts, lupus, and symptoms have to be present over 6 weeks. Typical presentation includes arthritis of the hands, the metacarpals, and the wrists, symmetric polyarthritis, rheumatoid nodules, radiologic changes, and then morning stiffness that lasts for several hours, unlike osteoarthritis, which typically lasts less than 30 minutes. Signs and symptoms: morning stiffness lasting several hours. Joint pain and stiffness develops insidiously over weeks to months. You will see an associated constitutional sign or symptom such as fatigue, low-grade fever, malaise, weakness, weight loss, anorexic. They just don't feel well. Extra-articular involvement may be seen and may manifest as Sjogren's syndrome, vasculitis, pulmonary nodules, Feltes syndrome, which is splenomegaly, anemia, and thrombocytopenia, soft tissue swelling and tenderness and erythema, spongy joints, warm, tender to touch, gelling or stiffening up after prolonged immobility. On physical exam, total physical exam head to toe is necessary because of possible extra-articular findings. You may see subcutaneous nodules, pleural effusion, pericarditis. Splenomegaly can occur in up to 15% of patients with leukopenia, lymphadenopathy, and vasculitis. They may be febrile. You'll note soft tissue swelling, muscle atrophy, effusions, decreased range of motion, strength, thickening of the volar or palmar aspect of the wrist, symmetric changes, soft tissue nodules, popliteal Baker cysts behind the knees. Check for various deformities such as swan, the neck, mallet finger, boutonniere. The MCP joint with ulnar deviation is a characteristic deformity that we see with rheumatoid arthritis over time. Diagnostic tests again: CBC may show mild to moderate anemia, that anemia of chronic disease. It's going to be normochromic, normocytic. Elevated SED rate, elevated rheumatoid factor. So 25% though of patients who have RA have a negative titer or normal titer. It could take 18 months to become positive. So rheumatoid factor also elevated with infective endocarditis and hepatitis C. And you'll see the anti-CCP antibodies are positive as well. ANA is more reliable in lupus than rheumatoid arthritis. C-reactive protein would be elevated and can help to monitor the progression. LFTs can be elevated if there's associated hepatitis. Creatinine, synovial fluid aspiration. You're going to see high white blood cells and look for crystals and culture insensitivity. So you want baseline X-ray to monitor disease progression. Early changes include that juxta-articular osteopenia and soft tissue swelling. 70% of patients develop radiographic damage in 3 years, but the first 2 years you may see a normal X-ray, so that does not exclude the disease. Osteoporosis occurs among menopausal women who are at greatest risk due to estrogen deficiency. Weight-bearing exercise, 1,200 milligrams of calcium consumption daily, and maintain adequate vitamin D can help prevent osteoporosis. The test of choice is the DEXA bone density test, so a bone mineral density 2.5 or more standard deviations below the reference range, or the young adult female reference range. So the T-score, a positive T-score would be less than or equal to a minus 2.5 standard deviations. Okie doke. So let's move on to ortho x-rays. So it is important to understand what normal looks like in order to diagnose abnormal. So comparison views can be helpful. You can miss abnormalities, especially in kiddos. So you need to know the anatomical location in the view you want to see. Positioning is going to be helpful to get the best imaging. One view is no view, so consider weight bearing and non-weight bearing, for example, too, on x-ray. Provide relevant information such as describing the mechanism of injury, the location and tenderness, or physical exam abnormalities. That's going to help improve the reading of the image. There's a systemic approach to reading x-rays. So the ABCs include A is alignment and adequacy, so you know the view and the adequacy of exposure. Alignment, the type of views taken and anatomical site visualized. Adequacy refers to the correct beam penetration, correct exposure. Joints above and below are included. The B of the ABCs, bones, outline and density. So the outline follows the contours of the bone and evaluate for any abnormalities. Density, you look at each bone in sequence. Radiolucent equals thinner bones. Osteoporotic bones. Radioopaque are thicker than the surrounding bone. Can differentiate Paget's disease and osteomyelitis by looking at the density. And then the C refers to cartilage, so the outline, joint space, and loose bodies. It may not be seen on plain x-ray. Cartilage is invisible, but the space is what you would see. And this may look fine and may require further evaluation with CT or MRI. Densities on x-ray. Dark black equals air, fat is dark gray or charcoal, soft tissue is gray, bone is light gray, metal is bright white. So in osteoarthritis, we'd see narrowed joint space, and then the bone might have a washed out appearance. There are different classifications of fracture. A simple closed fracture is a fracture that does not break the skin. A compound or open fracture breaks the skin, resulting in increased risk of infection. This is a medical emergency. Transverse fractures break straight across horizontally. These may have a higher chance of non-union and healing. Linear is a vertical fracture. Oblique is non-displaced, diagonal angle, but the bone is still connected. Oblique displaced is diagonal angle, but the bone is separated. Spiral forms a twisting motion or a torque. This might be an indicator of abuse, so be careful when evaluating these. Green stick fractures are common with kids. The outer edge is broken, but the inner edge is sort of flexed and not broken. Comminuted means it's ruptured with multiple fragments. Intra-articular fracture occurs within the joint space. Impaction fracture, broken ends of the bone are jammed together by force of injury. Compression fracture of the spine, for example, in osteoporosis or trauma. Spine and osteoporosis by far most common there. Avulsion fracture, tendon or ligament attached to the bone. When the soft tissue is pulled, it pulls a piece or a fleck of the corner of the bone with it. This commonly occurs in ankles. Stress fractures recur as a result of repetitive activity or overuse and may only be visible on the MRI. A segmental fracture is at least two separate fractures, lines together, isolating a bone segment. So it's within the same bone segment. A pathological fracture is a result of an underlying disease rather than an acute injury. And then there are Salter-Harris classifications of growth plate injury. So in a Salter-Harris 1, the injury is across the bone. A 2 is across the bone and up. 3 is across the bone and down. 4 is across bone up and down. And a Salter-Harris 5 is when the growth plate is impacted or crushed together. So bone damage and growth can be impacted with these types of fractures. 1 is the simplest, severity increase with number 5 being most severe. Shoulder anatomy, review the shoulder anatomy. So when you're ordering, be specific about the view. Glenohumeral arthritis requires an axillary view with abduction. That eliminates the joint space so it looks different. Proximal humerus fractures may displace and need surgery. That ice cream slip off the cone displacement. Greater tuberosity avulsion from a rotator cuff injury. Clavicle fractures, more often surgical for non-union comminuted fractures. Check for tenting of the skin, wound, and complications. Rotator cuff tendonitis, may not see this on an x-ray. Calcifications may be visible. Any arthropathy, which is a chronic and retracted tear of the supraspinatus and infraspinatus tendons, will allow the humeral head to rise. This is irreparable, complete loss of joint space. A dislocation, the traumatic urinary Bankart lesion of the anterior labrum. This is a surgical condition and is often missed. The dislocation can be represented by a Hill-Sachs lesion. In this case, the humeral head bangs into the glenoid. You need the axillary view to view the posterior shoulder dislocation, and this is missed in 50% of the cases. So the labrum is the protective ring of cartilage that surrounds the shoulder, that's found in the shoulder and hip joints. It adds bulk and deepens to prevent subluxation. You need an MRI to see the labrum. There are different types of labral tears, including a slap tear, anterior or posterior. So again, review elbow anatomy. The Sale sign is displacement of the anterior or posterior fat pads and can indicate occult fractures of the elbow in pediatric patients. You get two views of the elbow. You may miss the intra-articular fracture. That requires immediate surgery if we don't get both views. Dislocations may be uncomplicated, more complicated if there's a fracture associated with it. Forearm fractures, then distal radius buccal fracture results in a ripple or fold in the bone. It's more visible on the lateral view. A fall on an outstretched hand could be missed. This could be missed at home. It's still hurting after a few days. So an older patient may have compression and require a plate and a screw to maintain the position as it heals for that distal radial buccal fracture. Scaphoid fracture, remember, is the anatomic snuff box. It's non-union. It could require surgery to avoid arthritis long term. Typically, you need an MRI to see that scaphoid fracture. Mallet finger is the avulsion injury from extensor tendon rupture. The extension split You'll splint 6 to 8 weeks to heal in proper alignment. It's a long process with the mallet finger, but it is usually non-surgical. Fingers can be easily missed. They need to be x-rayed. And the knee. Review the anatomy. The Osgood-Schlatter disease, remember, is chronic inflammation and irritation. It may get extra calcification. Pain goes away after the growth plate seals. So it's self-limiting. The patella fracture is a horizontal fracture, superior and inferior. If it's not attached, you can't straighten the leg, and they would not be able to do a straight leg raise. So it involves loss of the extensor mechanism of the knee. The sunrise view looks down on the patella and patellofemoral groove. Some patients have bipartite and tripartite patella. That's a chronic issue. And so no treatment if asymptomatic. So assess if they don't have any pain, you may not need it. But to evaluate the patellofemoral joint and to see patellar instability, you want to get the sunrise view. An occult tibial fracture may need other imaging. The tibial plateau fractures, you can compare x-rays, MRI, and CT to get the best images. A Sagond fracture is an avulsion fracture that occurs from an ACL tear. Does not occur in all ACL tears. The Lockman maneuver is the only way without imaging to know if there is an ACL tear. You may see bone bruising on the x-ray from the impact. Medial meniscus, lateral view is best. The cartilage catches, locks, and rubs on the articular cartilage, causing damage and arthritis. So review the ankle anatomy. The AP mortis view, the anterior-posterior mortis view, is part of a 3-view series of the distal tibia, distal fibula, and proximal fifth metatarsal. Allows for the assessment of the mortis joint, which includes the articulation of the tibial plafond and 2 malleoli with the talar dome. It's most commonly indicated in cases of trauma to the ankle. Avulsion fracture can occur with more severe sprains. Treatment is the same. The Maisonneuve fracture is a specific ankle fracture that can be missed, occurs in all ages, occurs from rolling ankle injury. Non-weight-bearing foam looks normal, but there's a proximal fibular fracture, so this requires surgery. It's much more complicated with delay in diagnosis, which is why getting a weight-bearing image can be helpful. Bimalleolar ankle fractures affects both bones of the ankle. A trimalleolar ankle fracture affects the lateral, medial, and posterior malleolus, and then the Lisfranc is a tarso-metatarsal joint fracture dislocation. Some mechanism of injuries include falls, motor vehicle accidents, or like athletics, dancers in particular. On physical exam, you'll get midfoot swelling, arch plane, and plantar ecchymosis with the Lisfranc injury. Foot. Charcot's arthropathy occurs in patients with diabetes. It's a progressive joint disease following loss of sensation. So among people with type 1 diabetes, it occurs in the 5th decade of life, and type 2, it's more the 6th decade. It's later, the 6th decade. You see swelling, pain, loss of function, loss of feeling, erythema. It looks like an infection. You see this dependent rubra, but you elevate the leg and the redness goes away. That's how you differentiate. This is often misdiagnosed as cellulitis. In this case, you have strict non-weight bearing for 6 to 9 months, weekly x-rays, and unfortunately it can happen again within weeks, even after repair. And then you may have congenital abnormalities that you may be noted. Let's move on to reproductive. So, abnormal uterine bleeding. Remember the Palm-Cohen system for classification of abnormal uterine bleeding. The palm refers to the structural abnormalities, and PALM stands for P, polyps, A, adenomyosis, L, leiomyoma, M, malignancy, and hyperplasia. So the polyps are benign, can be cervical or endometrial. The cervical are easily visualized on exam, and then this you may notice bleeding after sexual intercourse is one of the presentations for a cervical polyp. Adenomyosis is endometrial tissue that grows within the myometrium. It's common among multiparous women and those over 40 after having had multiple uterine procedures. It is associated with miscarriage, DNC, endometrial resection, C-section, and tamoxifen use. So there's not really any great diagnostic imaging to diagnose adenomyosis, unfortunately. Ultrasound and MRI are not diagnostic. The only way is on pathology after a hysterectomy, which is sort of unfortunate. So it's a diagnosis of exclusion until then, oftentimes. Leiomyoma, they could be submucosal or other. So these are the fibroids, right? Uterine fibroids. Most common benign pelvic tumor classified by location in the myometrium or uterus, not the size. It's the leading indicator for hysterectomy. Submucosal or endometrial are most likely to cause abnormal uterine bleeding. Other types are subserosal, which is outside the uterus, and intramural, which is most prevalent inside the uterine wall. The M on the palm, malignancy and hyperplasia. This is rare in reproductive age women with a normal BMI who do not have PCOS. Increased risk of endometrial cancer when you have hyperplasia. Typically age 50 to 70 on unopposed estrogen treatment, which shouldn't happen. Tamoxifen, menopause over the age of 55, nulliparity, obesity, PCOS, diabetes, all increased risk. Increased family history of endometrial, ovarian, breast, or colon cancer. Most common signs of endometrial cancer when we're looking at malignancy are abnormal uterine bleeding and postmenopausal bleeding. So only 20% have the disease while still having regular periods, typically over the age of 40. So this is most commonly among women who are in that peri or menopausal phase. Cancer of the cervix, 3% of cases, rates significantly reduced with the availability of the Gardasil or HPV 9-valent vaccine. Risk factors include endometrial cancer. For endometrial cancer would be over the age of 40, a woman in the perimenopause or menopausal phase of life. Risk for cervical cancer, this almost never occurs in virginal women. So having had the HPV virus puts you at increased risk for cervical cancer. So low socioeconomic status, we see smoking increases incidence in multiple partners for the patient, or if a partner has it, obviously, has HPV or exposure to HPV. So Cohen are the non-structural abnormalities that cause abnormal uterine bleeding. The C stands for COEIN. The C is coagulopathy. O is ovulatory dysfunction. I is iatrogenic. E is endometrial. And N is not yet classified. So we'll go through each of these. So coagulopathy. So this accounts for 13% of abnormal uterine bleeding. It's often missed or diagnosed late. So von Willebrand's disease is a common inherited bleeding disorder, 20 to 30% of young women with a heavy bleed. So you want to screen all adolescents and young women with heavy menstrual bleeding, easy bruising, prolonged bleed after dental work, etc. And you test with von Willebrand factor activity, and factor VIII activity. Iatrogenic include anticoagulants. So if someone is on anticoagulants, it could cause abnormal bleeding right in the menstrual period. Acute leukemia results in thrombocytopenia, anemia, and leukocytosis. Thrombocytopenia, immune thrombocytopenic purpura, ITP, hypersplenism, chronic renal failure. Advanced liver disease, and then so labs you would want to check for all these include hemoglobin, hematocrit, the CBC with diff, PT, PTT, check stool for blood, platelets, and factor V. So ovulatory dysfunction is a very common cause of abnormal uterine bleeding. So usually it's uterine bleeding that's not associated with ovulation. The patient's not ovulating. What you'll see are abnormal menstrual cycles, could be heavy or light. May see endometrial hyperplasia on an ultrasound. Physiologic causes of anovulation. So there are physiologic and pathologic causes. Reasons we don't ovulate that are quote unquote normal or physiologic include pregnancy, lactation, perimenarche, so right around the time of the onset of periods, perimenopause, obesity or underweight, BMI under 18 specifically, and or excessive exercise. So Olympic athletes, for example, those in the Olympic athletic triad, we may see just a physiologic change that results in anovulation. Pathologic changes include hyperandrogenic disorders like PCOS, hypothalamic dysfunction, for example, from anorexia nervosa, hyperprolactinemia, which is commonly associated with underlying autoimmune conditions like endometriosis, PCOS, Hashimoto's, lupus, Raynaud's, and nickel allergy. Iatrogenic causes of anovulation include chemotherapy, radiation, and some medications. Certainly OCs prevent ovulation, and that's their therapeutic effect. Thyroid disease and primary pituitary disorder.